Hello, my name is Sandra Kurtin. I'm a nurse practitioner, director of advanced practice and clinical integration at the University of Arizona Cancer Center in Tucson, Arizona. And I'm here today to talk to you about benign hematology from a primary care perspective. I think it's important, first of all, to really revisit hematopoiesis. And I know when I see patients that are referred for benign hematology, I'm always thinking about what the bone marrow does, what cell lines there are, and then what I might be looking at when reviewing a patient's record. So it's important to keep in mind that we have our pluripotent or multipotent stem cell that becomes committed either to a myeloid cell line or a lymphoid cell line. From that lymphoid cell line, we get our B and T lymphocytes, which ultimately those B lymphocytes can become plasma cells. And then from our myeloid cell line, we get our red blood cells, platelets, and granulocytes. And so when we're looking at patients presenting with abnormal counts, it's important to really consider the overall picture of the bone marrow and its function. I think more recently, we've understood that beyond just simple growth factors that we've known about for many years, we now know that there are other molecular attributes that drive either normal or abnormal processes. So it's also important as a clinician in a benign heme clinic or in an oncology clinic to be considering this other level of information and how the bone marrow works or doesn't work in the case of patients presenting with abnormal findings. So the basic principles then of benign hematology, we have patients referred for consultation, and generally they have blood counts that are out of range. And often these are just annual visits and the patient's not symptomatic. There are some cases where patients are having symptoms as well, but often it's just an incidental finding. And so when I look at the myeloid lineage, red blood cells, we see either anemia, low counts, or erythrocytosis, high red cell count. In terms of white blood cells, again, it can be either lineage. So we can see low or high lymphocytes, low or high granulocytes. And then platelets can either be high or low, thrombocytopenia or thrombocytosis. For cytopenias or elevated elements of the CBC, this can happen because of an abnormal bone marrow process or peripheral destruction or some combination of both. So I always explain to patients, are you making cells like you should and then they're being destroyed, or are you not making them? For underlying disorders, this can include either primary, either acquired or hereditary, or secondary. And many of the patients that I see, these are secondary processes to other underlying diseases or processes. And we're going to talk more about that as we go through this. So what is the role of the advanced practitioner then in the diagnosis and management of benign hematology? I think it's really critical to review the past medical history and to look back. This can sometimes be challenging if you only have, for instance, one set of labs. But also look for potential hereditary disorders. Is there any family history or any comorbidities that might be associated with these secondary processes? Always do a medication reconciliation, review their meds, look at, have there been any recent changes that align with the appearance of these abnormalities? Have they been hospitalized? I often map out counts over time. And if you see a really group of or a cluster of counts all in a course of a few days, then that means they were probably in the hospital. And often you'll find that those abnormalities are correlated with those acute processes and then correct over time. So that can answer your question right away. Looking for symptoms and their H&P. So do they have symptoms that align with either these high or low counts? Again, looking at the chronicity of these changes, I've found several patients where these abnormalities have been present for 10 or more years, and they saw a new provider and had counts, and that person hadn't looked back over time to find that this was indeed a chronic finding. It doesn't mean that you won't pursue that, but it's different than something that is acute or progressive. And then are there other physical findings, adenopathy, hepatosplenomegaly and such, that might affect their blood counts? And hepatic cirrhosis is often a common problem here. And then we're going to order testing and do the workup according to what our suspicions might be. So the most common reasons for benign heme referral, this is a great paper looking at advanced practitioners in Mayo Clinic and looking at, where they felt they needed more information about benign heme and, and how important that was in learning. But again, looking at too many, too few. The other place that we see referrals are people that have abnormal serum or urine protein levels. And then very commonly now with the sensitivity of MRIs, when people have MRIs of the spine or other areas of the pelvis, and they see this heterogeneous uptake in an MRI, there's always, cannot completely exclude an underlying bone marrow disorder. And I would say 9 times out of 10, this ends up being a reactive process, but it requires evaluation. So let's start with anemia. When we look at anemia, we're going to say, are the cells too big, macrocytic, or too small, microcytic? And when we look at that, we look at an MCV. And so if it's over 100, we're going to begin to question, could this be an underlying process? Macrocytosis or macrocytic anemia is one component where we might be suspicious about something like myelodysplastic syndrome. And we get a lot of referrals with that concern in older adults, but you need to go further. So we're going to look for a reticulocyte count. In the presence of anemia, that reticulocyte count, which is the precursor to a mature red blood cell, should be elevated. That tells you the marrow's trying to recover. If that's not, then we're going to look for other processes like hemolysis or hypersplenism. And then, of course, nutritional deficiencies or alcoholism can be another factor, liver disease, as you can see here. So working through that algorithm. Now, when to refer to hematology if you're in primary care is really dependent upon your level of comfort with working this patient up. So we get a lot of patients where they've done some preliminary workup and others where they have not. And so it's just important to evaluate how much has been done so far and where do you need to pick up if you are a person that's seeing these patients for a hematology consult. For the microcytic anemias, the most common cause here is iron deficiency. And so we're going to ask the question about blood loss from any source and then do our iron studies and replace that and then reevaluate. We see a number of patients who have had gastric bypass surgeries. This becomes an inevitable and chronic problem for those patients for both B12 and iron deficiency. But again, asking all of those appropriate questions in that history where we would look for blood loss, which is how you lose iron. There's no other way to become iron deficient other than to lose blood, with the exception of very rare malabsorption syndromes. So again, underproduction, increased destruction, blood loss. We're going to look at the CBC diff and platelets. We're going to always review a peripheral smear, either ourselves or by pathology, to look for abnormal shapes of cells, looking for that reticulocyte response, and then doing the additional workup for things that affect red blood cell production, including chronic kidney disease, liver disease, whether or not they have an adequate erythropoietin response. Iron B12 we talked about. For B12, we also order homocysteine and methylmalonic acid, which will show you a subset of patients who have functional deficiency, even though their B12 might be normal. Folate, of course, in folks with a very low MCV with some question of hereditary syndromes like thalassemia, we'll do hemoglobin electrophoresis, although that is not something we do for everybody. The hemolysis screen, which includes that haptoglobin LDH, direct antibody testing, and retic, and then thyroid plays a role as well as testosterone. Some of the other plausible explanations for anemia can include a number of different diseases, And I won't go through all of this in great detail, but it's important to know how many different possible alternative etiologies there might be to anemia. So outside of true bone marrow disorders or cancers, there are a number of diagnoses that play a role and can be associated with anemia. You can see there are also consumption or destruction abnormalities that can be associated with anemia. One of the common ones are mechanical valves. And these patients with mechanical valves have this chronic shearing of red blood cells and hemolysis. So you'll see a hemolysis pattern. Also, patients with liver disease who develop hepatosplenomegaly can have sequestering of those cells in the spleen and abnormal production of cells because of liver dysfunction. We talked about lack of nutrients. And then, of course, there are the people that have treatment-related anemia by virtue of not just chemotherapeutic agents, but other drugs that can reduce red blood cells. Then when we look at red blood cells that are too high or erythrocytosis, the biggest questions we always ask is, are you a smoker? Do you have sleep apnea? So anything that shifts that oxygen dissociation curve, making the body think it doesn't have enough red blood cells to carry oxygen, so it makes more red blood cells. So that's one of the first questions you ask. Carbon monoxide poisoning in an acute setting, obviously, but there can also be some right to left cardiopulmonary shunt that can do this. High altitude can make that shift a little bit, although usually not as high as we see in someone who has sleep apnea or is a heavy smoker or who is on testosterone or androgen therapy. We also would look for rare renal tumors. Are they getting erythropoietin? Unlikely when they're initially referred, and then some other extremely rare underlying malignancies here. But oftentimes you'll find, that they do have sleep apnea, or they are a heavy smoker, or they've been getting testosterone injections, in which case you remove the offending element there and recheck. For those folks where there isn't a plausible alternative explanation, we're going to test for myeloproliferative neoplasms and can do this in peripheral blood just by easily checking a JAK2 or myeloproliferative neoplasm panel to see if they do indeed have a myeloproliferative neoplasm. Then when we shift to thrombocytopenia, so low platelets, one of the first questions are they a clumper? And so I always use that term, are you a clumper? If you let that CBC sit in a tube, platelets will clump just by virtue of what they do. And in fact, this is not real thrombocytopenia, but rather a mechanical or artifact from the processing of the blood. And so we often just rerun it in our lab where we can send it upstairs quickly and have it run immediately in an EDTA tube, and that removes the question altogether. And usually we can answer that question in about 20 or 30 minutes. If it's truly thrombocytopenia, then we start to ask the question, do we see schistocytes? These are fragmented cells that you'll see on a peripheral smear, and then we're going to look for some destructive process. Do we see other things in that profile that might suggest abnormalities in those other cell lines, making us suspicious of an underlying disease? And then are there other findings in the physical exam that might lend us or lead us down the path to look for other things like ITP, for instance, or DIC? And in the era of COVID now, the concern over TTP in patients who are COVID positive. For ITP, then that's a different workup, and we're going to look for contributing factors there, do a broader analysis for what the underlying cause is. So immune thrombocytopenia is a secondary process, it's not the primary process. It's always reflective of some other abnormal underlying disease. And so you can see here that extended workup will look for both clotting abnormalities and other infectious etiologies or chronic diseases that might be the offending factor. When we look for high platelets, very similar to high red blood cells, we're going to look for reactive processes. One of the most common findings or underlying causes here is iron deficiency, where you get a reactive thrombocytosis. So in a patient with microcytosis, microcytic anemia, where you suspect iron deficiency, it may very well be that that's the cause of the thrombocytosis. Correcting that iron should correct that. And if it doesn't, then we're going to go down that path of further analysis. Similarly, infection, inflammation can cause a secondary thrombocytosis. But if you can't explain it, again, we're going to look for myeloproliferative neoplasms and do that similar testing that we just talked about, where we're looking for any elevation of this myeloid lineage. Then when we look at leukocytosis, so elevated white blood cell counts, again, you need to determine what's the cell line. Is it lymphoid or is it myeloid? So the granulocytes, basophils, the eosinophils, monocytes, and neutrophils can be elevated for a number of reasons that you see here. Lymphocytes similarly can be reactive in the setting of acute or chronic infections, but also can be elevated in leukemias or other malignancies. So similarly here, the algorithm is just to confirm that this is indeed true. Also look at that history very carefully for any, is it chronic or acute? And is there some underlying causative agent or process, and work through each of those cell lines individually to understand what that trend might look like. The last thing I want to touch on in the last few minutes is chronic liver disease, and we've seen more and more of this. And this is also something that we're seeing in our COVID long haul patients, where there have been some hepatic damage. But often people with fatty liver or non-alcoholic cirrhosis or alcoholic cirrhosis, you make thrombopoietin, which is a stimulator of platelets in your liver. And so when the liver is not well, you don't do that very well. So thrombocytopenia is actually very common in chronic liver disease. And then there are other mechanisms. That's secondary splenomegaly, where the spleen, basically those platelets are sequestered in the spleen along with other counts. That shifting of the systemic circulation. You can have direct marrow suppression in the setting of chronic liver disease, and then shear stress, so breakdown of these cells via cirrhosis, and that's true for all of the cell lines, all the myeloid cell lines particularly. Also, these patients are more prone to infections, particularly hepatitis, and can have iron overload, which is toxic to the tissue and causes further damage. Usually these patients run their platelets somewhere between 50 and 60,000. And that's all I have. I hope you've enjoyed this brief overview of common findings for benign hematology and when you might refer, or as a AP in oncology, be involved in the management of these patients. Thank you.